Good evening, ladies and gentlemen. How's everyone doing today? Welcome, welcome, welcome. It is Friday. Ladies, it's Friday.
That's right.
It's Friday. It's a beautiful thing, beautiful thing. And so welcome to another exciting time with Urban Birds and Bees. I am Dr. Peri. I'm your host and moderator for Urban Birds and Bees. And, you know, we're about to talk about something that I'm really just kind of finding out about. This whole thing, and you know, what's interesting as men, maybe that would be appropriate, but apparently a lot of women are just really coming to the knowledge of this whole thing. It's been called perimenopause and dating. Perimenopause and dating. Very interesting topic, and from what I hear, it says timely as well, right, Dr. Hines?
Quite timely.
Yeah, so anyway, so I want to thank you guys for joining in, and hi you guys on Facebook Live. We'll be before you just about like 45, 50 minutes, less than an hour. But we're going to get right to it. I have two amazing guests this evening. So let's talk about our guests that we have to dive into some big discussion. We have Lynn Beatty, long-time friend, long-time homie. What's going on with you?
Exactly.
Okay. Lynn Beatty is a powerhouse healthcare veteran with more than 3 decades of experience. 3 decades. I mean, she started since she was 9 years old.
Yeah, right.
Yeah, exactly.
Okay. Spanning critical care nursing, hospital operations, and national leadership roles in major health systems. She has led high-stakes partnerships in organizations, like GE Healthcare, earning the reputation for strategy, excellence, and heart-centered leadership. I can vouch for that. Definitely heart leadership, for sure. So beyond her corporate impact, Lynn is a long-time leader of the National Black India Association Los Angeles chapter, a dedicated mentor. She's mentored me as well. And an active member of Delta Sigma Theta. That's what's it.
Delta
What's it?
Sigma
What does
Theta
it?
Sorority
What does it?
Incorporated.
Delta Sigma Theta? I didn't say that? I got that right.
Yeah.
Okay.
That's all right. That's all right.
Okay.
I give you that one time.
There you
Okay.
go.
Thank you. Most importantly, she's a proud mom, and I mean, I know you guys gonna trip out, but she's actually a grandmother too.
Right.
Who brings wisdom, humor, and real-world insight to every conversation. Big round of applause for Lynn Beatty. Woo! Crowd goes wild, yeah. And then now we have the one and only Dr. Tanya Hines, MD, who is a board-certified OBGYN and one of Los Angeles' most trusted voices in complex medical issues with clarity and compassion. She is a sought-after speaker, mentor, and community educator. Dr. Hines brings warmth, wisdom, and real-world insight to every conversation, especially when it comes to empowering women to take control of their bodies, their health, and their lives. And she is also a member of Delta Sigma Theta Sorority Incorporated.
You know I am not Delta Sigma Theta. You know that?
What?
I am not. I am not soror.
I thought you was a Delta.
Sure.
No.
You call her sorority too?
No, she said it. That's what I said.
Can we go back and rewind? Oh, no.
They gave me money
They gave you money. Okay.
for college, and so did the other alphabet.
That means you're going to pledge grad chapter then,
I
right?
have, you know,
You're going to grad chapter?
I know that's my mother-in-law wants me to. Hey,
Anyway,
I do
big
have
round of-
quite an allegiance to DST.
Okay, yeah, so I don't know if it's going to be a little competition because AK is going to be going to look out
Oh,
to
yeah, I love them too.
Some Gamma Rose.
Okay, I don't know a lot of things. Don't give me a try.
Okay. Anyway, so let's dive right in. We're going to talk about the clinical and cultural foundation of all this. So, Dr. Hines, would like to start with you. First of all, can you explain to our listening audience exactly, on a basic 101 fundamental level, what is perimenopause?
Sure. Okay, I'll give you the maybe 30-second version.
Yeah.
So very quickly in a woman's life, on average, between age 10 to 12 is when most young girls start their period, plus or minus 2 years.
Okay.
So pretty early, as low as 8 and as high as about 14. You'll get probably most of young girls who start their period. So imagine that that's the beginning of your womanhood and fertility. Perimenopause is a transitional phase that is associated with a decrease in the amount of estrogen that we all make as women as you approach the absence and significant decrease in estrogen at menopause. So remember I said age 10 to 12? Perimenopause to some extent starts probably in the late 30s for some patients and can go all the way through the 40s. But the key number is the average age of menopause in this country is 51. plus or minus 5. So that's as early as 46 and as late maybe as 56. And you'll get most women who have stopped having their period. This is important. So if 10 to 12 is when we first start our period, we start to lose it in the late 30s. For most people, it's early to lose your period at age 40, but it's still considered normal, although early. So menopause, 51, no more period, plus or minus 5. Peri, all the time leading up to it. So I say, when I talk with my patients, as you said, I explained it in a way that people understand,
Right.
that there is this process by which you start to enter into decreased estrogen. You don't know that's happening, but it is associated with a change in your fertility and the ability to get pregnant as quickly, perhaps, and as easily as when you're in your 20s. It may, and it is associated with changes in temperature regulation. We call that thermoregulation. So you have hot flashes, vaginal dryness, mood swings, irritability.
So in perimenopause, a woman can still get pregnant?
Absolutely.
Okay.
She still got a uterus. Ovaries is working.
Okay.
But they're just not as predictable. They're not as, and really, they're just not. So the process of leading up to it, so I call perimenopause, you're entering to the process. It's the storm, and then as you start to get through it, it's the menopause, and then it's postmenopause. So it's pre-menopause, perimenopause, postmenopause.
Okay.
Basically, before, during, and
after. Got it. So I'm curious, to stay with you really quick, Dr. Hines. What is it that you wish that most men and women understood about perimenopause that constantly gets misunderstood from your understanding, your vantage point?
It's not a disease.
Men hear that. It's not? What do you mean?
Okay, let's be real clear. A disease is some entity by which you make the diagnosis and you have some treatment that you expect it to go away, or at least to be able to treat.
Right.
Menopause is a stage and a transition in life in which you used to have more estrogen than you do. And as you transition through that process, you will lose your period forever. You will no longer be able to carry a child, but you will still be an exceptional woman.
Oh, okay.
And that is the menopause.
Okay, gotcha.
Can I add?
Yeah, you got it.
This also happens to men. They just don't want to talk about it.
What?
Yeah.
Period?
Yeah,
we
yeah,
have
yeah.
we have a cycle?
No, what they have is
Midlife crisis?
no, they have high concentrations of testosterone as they're young men, and they're very virile, and they're very fertile. And as they get older, they have a change in their testosterone production that leads to a change in the way that they look, and their muscle mass, and their stamina, and whatever else you want to talk
I
about.
know what you're talking about, right?
And then as they,
I know what you're talking
as
about.
they approach age, 40, 50 plus, they're not exactly the same man that they used to be when they were 20. However, there is no, per se, outward reflection of that. Which, versus for women, you can see that there's decreased fertility and they don't have a period anymore, and they have hot flashes and things like that. But there is a syndrome in men associated with lower testosterone, and you see all those commercials on TV talking about what happens when they don't have as much hormone. I just wanted to throw that out there because this is not some isolated situation.
Look, forget you.
Okay. Okay.
Okay, so Urban Birds and Bees, what we do here, we like to keep it stacked, we keep it buck, we keep it honest, we keep it transparent. So we're gonna ask Lynn to go into a little transparency here. Now both our panelists were briefed in terms of questions they're gonna be asked, so they didn't give me a thumbs down, so I'm going for the gusto. Okay, so Lynn, so talk about a little bit when you went through this transition, okay? And what were some things that you were not prepared for, emotionally and physically, and how did it show up for you in dating?
So, kind of to echo what Dr. Tanya had said is that, as women, we kind of hear about menopause, very loosely though. We expect that maybe in our 50s. But we really, until recent years, haven't heard about the concept of perimenopause.
Right.
So when you start experiencing some of the changes in your body, so like for me, I put on like almost 20 pounds.
Absolutely.
And you've known me.
Weight gain is pretty common.
Well, the weight gain is very common, and what's disturbing is that even when I spoke to my female physician, she said, "Oh, that has nothing to do with hormones. Just watch your diet." I've always been a relatively active person, and still, I hadn't changed my diet, hadn't changed my activity. Matter of fact, I was trying to work out more, and still I'm gaining weight. So I didn't really know what the problem was and what I was doing wrong, but I really wasn't doing anything wrong. It was just my body changing. So then that cascades into my sense of feeling sexy. And so as it relates to dating, I mean, now I'm a little less, confident in my sexual appeal to men, even though, I've never been like a really big person, but it was abnormal for me, right? So you don't have as much confidence, and then, if you're getting to know somebody and things are going really well, and perhaps that moment of truth comes and maybe you're about to remove some of the clothing that you're wrapped up in, you're just not as confident. And then that translates into any sort of like feeling, sexually attractive and the sexuality of it all. And so definitely that was a...
So how did you manage that? That's kind of interesting. That's...
Well, and it tied into, the hot flashes and, the sleep disruptions and just a level of irritability. I've heard some real horror stories. I think I was blessed in some way.
And what she's describing, is this the perimenopause stage, what she's describing?
She's describing the entire, process.
Oh,
so, so we don't necessarily call it menopause until you add no period.
No period, okay.
But you have everything else. I just want to throw in there, because, I got you, my sister, is that once again, we don't talk about that women's currency with just beauty is also not talked about with regards to how men change as well, right?
Right.
So here you are at 40 years young or 45, and if you're dating a man who's in his 40s or 50s, he looks a certain way too. Now, don't get me wrong, there's some exceptions out there, but that distribution of fat changes. And so even if you're not necessarily bigger on the scale, there's less muscle mass. This has everything to do with estrogen and how it affects every single receptor in the body. There is no part of the female body that does not have an estrogen receptor. And so there's a distribution. So you start to have more fat along the midsection as opposed to the hips and thighs. Same thing with men. They always put more fat, you know what I'm saying, in the midsection.
Right.
But that shows, and I don't want to steal your thunder, there is a more free testosterone in women. We make testosterone just like men do, we just make far less. But now it's freer because it's less estrogen. And now you start to see acne, you start to see a change in how you are shaped. You start looking more like a man. You start having thinner hair in the places where men lose their hair. That's extremely a big deal.
Wow, wow. Well, okay, so I want to go back to Lynn for a second. Okay, so at some point while this was going on, did you begin to understand this was connected to this menopause cycle that Dr. Hines referred to? And to the degree that you did begin to get some insight on this, how, and particularly, look, I know you like to go on out good time. You like to hang out there and, look, don't let this professional demeanor fool you. She can cut up with the best of them. So, I mean, talk more about maybe the psychological component. You talk about like feeling sexy. Were there anything else that kind of stands out to you during this time as well, while you're kind of dealing with this phase?
So, and I don't know if there's something going on with my headphones, because I'm not hearing you through the headphones anymore, but...
Can you hear it now?
Now it's coming back.
Okay.
So, again, because I wasn't aware that this was, in my 40s, I wasn't aware of the perimenopause phase. I just knew that probably in my 50s I might be going through menopause. So as I'm having kind of some degree of an emotional roller coaster and more irritability and some other changes in my body, I'm wondering what's wrong with me, right? And so what I ended up doing though, after a few years, is I started to use the bioidentical hormones and got these little pellet things, and so that helped to kind of smooth things out. So that was very helpful.
It's like a synthetic hormone or something like that.
I'll let her describe exactly what it is.
Here we go. Okay. The main thing is that the source of where the estrogen is coming from is plant-based or synthetic, but ultimately it's still estrogen, progesterone, and depending upon the formulation, testosterone. It's how it's given. So as, you know, I got my Kaiser hat on, all right. You made me wear this white coat, okay? So since I got my coat on.
It's part of the aesthetics.
You know what I'm saying? I got to talk about evidence-based medicine. So when we use the word bioidentical as a board-certified OBGYN, that's kind of a taboo word, but it still means that you sought the advice of a professional.
I did. It was a physician.
Who said, I'm going to give you estrogen and progesterone and perhaps testosterone in a vehicle that addresses your symptoms and your needs. Does that make sense?
Yeah.
From the evidence-based standpoint, it says that because it is not research-based and there's not, you know, randomized controlled studies on the way that the medication is being given, and that the consistency from one product to another, from one person to another who provides it, that as a physician we cannot say that you should do that. But I can take this hat off and be me and say that I know that it works because it's binding to the same receptors that if I wrote you a prescription, it binds to. So it's estrogen regardless. It's progesterone, which is important in order to reduce the risk of uterine cancer. But the combination of both estrogen and progesterone from the 2002 Women's Health Initiative was very clear that it appeared that there was an increased risk associated with breast cancer. Now here we are 23 years later, and the newest and latest research shows that there are way more women who should have been given the opportunity to be on hormone replacement therapy that were not at increased risk for breast cancer or uterine cancer or heart attacks or strokes. So that is why this renewed interest in both the perimenopause and the menopausal transition in women who have gone through their last period within the past 10 years. So if you see a woman who's 55, remember I told you the range, and she says, I just lost my period a couple of years ago, I can't take it no more. She's absolutely a good candidate if she has a few things that you are absolute contraindications. So if she has active breast cancer, you cannot give her hormone replacement therapy. If she has unexplained vaginal bleeding, can't give that to her. If she has current uncontrolled hypertension, if she is being worked up or has a current heart attack, these are just absolutes. You cannot give the hormone replacement therapy. However, the research does show that it appears that in people who have a uterus, those patients are at slight increased risk for breast cancer, but not much. But the benefits associated with reduced hot flashes. And hot flashes are not just hot. We now know that they are associated with significant disturbance in sleep, and that poor sleep is associated with cardiovascular implications. So there's way more now that we know about the supplementation of both estrogen and progesterone, and if necessary, testosterone, that it does improve all-cause mortality, and that it is better for most patients than not giving it to them, depending upon how the patient presents. So ultimately, it is individualized treatment, and you were able to get good care from a physician who is going to follow you and to be consistent, and that's the key. It is not without risk, but its risk-benefit ratio is much better than we used to believe it was, and the delivery is different, right? We are using patches. We're not giving tablets as much as we used to. We know that that bypasses the liver so that it doesn't raise cholesterol. We know that people who don't have a uterus may have slightly increased risk associated with cardiovascular profile, but all-cause mortality, it appears to reduce colon cancer. Definitely those patients are sleeping better. Their overall mental health and well-being is better. And so we see less anxiety, less depression. Hormone estrogen is who we are as women. So think about the fact that you live the rest of your life, half of it to some extent, without estrogen. So for us to just walk around and say, I guess we just got to deal with it, no.
Yeah, that's interesting. But I want to go back to something that you talked about earlier. And I'm gonna come back to you.
I'm quiet.
In a second. No, you're good. You're good.
Yeah.
No, this is very interesting. I hope everybody listening. I mean, like, Tony, is this deep or what, bro? This is
I'm learning a lot. I'm gonna go to my wife and tell her everything.
Like,
about
please be
I'm
nice.
sorry.
No, we're the same age, so
So you talked about how like you went to the doctor and you saw the weight gain, and they said, "Oh no, that's not associated." At some point, it sounds like you did begin to understand that it was connected to this menopausal cycle.
Mm-hmm.
Okay.
At some point, I went to a different doctor.
Okay.
Ding.
Talk about that. Talk about that.
So there is a segment of the medical community, it would appear, that are considering themselves like menopause specialists.
Mm-hmm.
So generally as women, I mean, you can go to a family practice doctor if you'd like, but generally as women we go to an OBGYN,
Right.
at least especially during childbearing years, etc.
Right.
So, but at that point I was beyond childbearing years, well, I not really, but I wouldn't have no more. But, so I was just going to my family practice doctor, my general medicine doctor. That was kind of a flashback. My doctor wasn't general medicine, they don't call it that anymore, but family practice.
Right.
And she's the one that kind of poo-pooed it. And it was a woman, so, if I weren't in the clinical field
I'm gonna address that in a second too, but go ahead.
if I weren't in the clinical field myself, then I might have just taken it as a fact that there's something wrong with me and I'm, eating wrong or whatever. But I know full well, just like in any industry, in any specialty, in any profession, there are good, there are bad, and there's everything in between. And so I found a doctor, a black female doctor that specialized in menopause care, and spoke to her, and that's how I was exposed to the option of these bioidentical hormones. I didn't take them orally. It was kind of a tablet pellet that was underneath my skin.
Mm-hmm.
And I did that for a few years, and it helped dramatically with all aspects of my life, including the sexuality and the relationships, because I was much more even keeled. I'm getting a good night's sleep, right? And that, we clinically we know, as Tanya mentioned, that when you're not getting a good night's sleep, it increases your risk of other medical problems. But it impacts your ability to interact with people on the job, as well as in your relationship. It can affect all aspects of your life, and then you're irritable because of the hormonal things that are going on, as well as the lack of sleep. And so that's how I kind of navigated through that process. So, but as it relates to kind of interacting with men, the person I was dating at the time, he didn't know I was doing that. And the only reason I bring that up is because there's still a perceived amount of shame around being in perimenopause or being menopausal, because so many men really don't know what it is, and there's such ageism in our culture anyway, in this country, and so you don't want to appear like.
So the shame is like, well, you don't want to seem like you're getting older or something like that.
Right,
Okay.
which is crazy because the person you're with is getting older as well, right?
That part.
But
what are you talking about?
But as women, I can only speak from my experience or my observations, is that women, there's a little bit, maybe a lot more pressure on us to stay young.
Mm-hmm.
Like I saw.
I would agree.
I saw kind of a video where someone was saying that in terms of dating older women, that her best years, or she's past her best years. What does that even mean?
Mm-hmm.
But that's kind of a perception.
That's another podcast.
Oh, I know. And don't even get me started on like when you're on dating apps and you see men that are in their 50s and 60s, but what they're looking for, someone in their 20s and 30s.
Yeah.
Don't get me started. That says a whole lot right there. Yeah.
Well,
You know what?
So, I'm sorry.
No. That's it. That's before I go way off on a different tangent.
So I'm gonna
Truth
just
tell.
throw out some assumptions. I'm gonna talk about some factual stuff, and then I
Okay.
want you to respond to it. So, particularly in the Black community, it seems like it's one extreme or the other. It's historically speaking,
Mm-hmm.
and maybe perhaps more associated with lower socioeconomic category.
Okay.
But not necessarily, it could be middle class as well. That either we're avoiding the doctor altogether, or we go to the doctor and whatever they say is absolutely 100% right, and there's not much self-advocacy. in terms of like, so like when Lynn pivoted and went to another doctor.
Right.
Okay. So recently, you know about Holly Berry, how
Oh,
she
yeah.
was championing AB 432, which was the Menopause Equity Act.
Right.
And one of the things that she was concerned about, and they advocated for in that bill, was that doctors would be incentivized to get more specific training to deal with menopause.
Right.
Which blew me away that in medical school, it's barely touched. We talked about this earlier with Dr. Renee Poole, and she said when she went to medical school, rarely was now she's a general internal
Right.
physician,
Right.
but hardly touched. So I'm listening to you.
Right.
You sound like a freaking expert at this.
Because
So-
I am an obstetrician gynecologist.
Yeah. So okay.
So it is my job to know.
Well, yeah, I would think so. But my understanding is, even those OBGYN category
Right.
physician aren't up on game, so to speak, with the specifics to the degree like I hear that you are. Now, help me understand about this evolution, so to speak, and also speak to the importance of being able to self-advocate, to be able to pivot and not get what they want, and how should they approach that? And, you know, somebody say, well, I'm not going to disagree with the doctor. That's the doctor, so to speak, right? So talk about that for a second.
So, once again, it's probably a whole nother podcast, but you want to talk about access to healthcare. So,
Yeah.
I'm gonna start with social determinants of health, and that means this is rooted in a system that was never created with us in mind. Healthcare, the medical field.
Okay.
So we are talking about a very patriarchal system that stems from providing healthcare basically to white male heterosexuals.
Yeah. Yeah.
And it has expanded, right, over time. They didn't let women physicians in med school until the late 1970s, like 1975, I believe.
Really?
So, yeah.
75?
1975, go look it up. Look, Roe v. Wade, 1971, and they
Yeah.
overturned it. So let's be clear.
Yeah, yeah.
You know, Ruth Bader Ginsburg, she might, yeah, but it was not a whole bunch of female judges. Let's be clear.
Right.
So when we say that, let me just get to the point. Access means everything. And if you don't have access to healthcare, period, whenever you do access it, you are in a critical state. It's acute, and that's the emergency room. And therefore, when you walk into the emergency room, you're not concerned about a hot flash. Either you bleeding out, or you got in a car accident, or something bad happened to you. To have access to a family physician or a primary care provider means now that some of your preventative care can be done. And so on top of your mammograms and your vaccinations and your otherwise checking your cholesterol, now you can talk to somebody about what your concerns are. In medical school, honestly, the only time you really hear about menopause is on your OBGYN rotation. And depending upon, and it is one of the 5 rotations: general surgery, family practice, pediatrics, OBGYN, and surgery. So those people, you have to talk to them. But
Right.
you really don't have to learn nothing. And if you're really there just, delivering babies, that's what you want to do, hang out in the clinic, you could act like you never learned anything.
Wow.
I don't recall having a lecture about it, except that I am in 4 years of residency as an obstetrician gynecologist. Remember, I said I got to know it.
Right.
I think the main issue is if you don't have access, you're going to talk about the things that are most important to you, and that's keeping your heart pumping,
Right.
your lungs breathing, and you're not dying. Advocacy stems from someone who feels confident enough with the money that they're paying for their health care that they can have a relationship with their physicians. Most people don't.
Right.
So there are people within the OBGYN subspecialty that are taking and have taken subspecialized courses through the Menopause Society. There's a whole society that really talks about a lot of details with regard to how we approach, and that includes women who have had breast cancer in the past. That includes people who we would think is an absolute contraindication, and that they're coming out with newer evidence-based research to show that it may not be. Those people also can get hormone replacement therapy depending upon how we give it, how much we give, and when we give it in the nature of their treatment. So there's a lot of detail. You can be certified to have specialized training. And in my department of 30 physicians approximately, 8 of us are black and female, bunch of unicorns, we're all that black girl magic. But what I'm saying is, in that group of the 8 of us, I believe there's at least 2 of us that are subspecialized with that training. I didn't feel I needed the training because I had physically gone through it. I'm like, I know exactly what this lady is talking to me about, and I sought a higher level and depth of education because it made a difference in my life.
Yeah.
So I think that makes a huge difference. But you're right, for black folk and brown folk, and for that matter, underinsured and underrepresented and low income, all those things. If you just have access to a physician, what you're probably not going to talk about is hot flashes.
Yeah.
You are going to be talking about this abdominal pain I've had and this mass growing over here and this, shortness of breath I got. That's what you're talking about.
Yeah.
So I feel like the discussion on menopause has taken a new life of its own because of someone like Halle Berry, which is already an issue.
Right.
Because remember, Halle said that she was misdiagnosed with herpes because she was having basically vaginal atrophy or thinning and drying, which led to a decrease in the ability of her personal parts to make natural lubrication.
Right.
Megan Thee Stallion, the WAP gone.
Yeah.
So if the WAP is gone, then she's having difficulty trying to figure out how to be intimate with her partner. Look, I am a gynecologist. If you can't tell me, who can you tell?
There may be some people that don't know what WAP is. Can we?
Don't go there.
WAP still.
Go look it up on Urban Dictionary. But that part, as you talk about dating, that's a big deal.
Yeah.
And I think that, first of all, people have to get up enough gumption to even come see me as a gynecologist, and they get pap smears and whatever. So the things that they share with me, as you talked about with dating, it's real hard to talk to somebody you just met.
Right.
And then to say that you may not feel as comfortable, and then, what lubricant you might need to bring with you, and then the kind of pre-foreplay you might need to engage in order to, rev that motor up, right? That's on the same other end too, but they don't want to talk about that. That's a whole other subject. But the key is, there is no blue pill for women, but there is a pink pill.
A pink pill?
A pink pill that is for, they call it hypoactive sexual desire. Okay. It's associated with an increase in 1 to 2 additional episodes of sexual intercourse in a 30-day period. But you can't drink alcohol if you take this pill because it increases your risk for fainting and it changes your blood pressure.
Oh, wow.
So I'm thinking you on a date and it's supposed to help you to increase your interest in sex. But you fainted because you had
Did you faint?
So you can see why the FDA approval on this medication ain't going so well. But I'm telling y'all the truth. You can look it up.
Okay, let's stay there for a second because I think this is critical, right? Because this is PG-13, so kids under 13.
Almost rated R.
I love it.
Exactly. Okay, so let's talk a little bit about that. Let's talk about the how hormones directly affect libido, moisture, desire, and sexual response. But more specifically, and let me say this before I finish my question. So those of you who don't know Dr. Tanya Hines, she is the OBGYN for most of black women I know in Los Angeles. She is either currently their physician or has been. In time, I know you kind of moved around in practice and with Kaiser. So, I mean, that is true.
Yeah,
I know a number of women that say, "Oh yeah, that's my OBGYN." Oh, it used to be. Oh yeah, look, it's. Matter of fact, when doing your birthday party, I put some things on Facebook. Women tell me, "Oh yeah, that's my OBGYN," or something like that. So I know you know a lot of secrets and a lot of information on folks. So you can write a book and put a lot of people on board. But that being said, so talk about the response, how it affects all those different areas we just talked about, but also talk about do these changes impact black women differently compared to other groups of women?
Supposedly, and Lynn, you I think it's nice if we kind of have a conversation here, that black women have more intensity in the number and frequency of hot flashes, and like that famous big
orgasm intensity. But anyway.
Okay, so the key. I'm gonna turn my brain on that one. So, okay, once again, estrogen to the rescue. Estrogen is very important for the ability to have arousal. So patients who are going through the perimenopausal transition take more time to become aroused, and then at the point where they are aroused with more vaginal natural lubrication, which is less because they're not making as much, that the peak to orgasm is longer and the intensity of the orgasm is less, and the ability, as you know, women can orgasm much more frequently, but without a what we call a reclamation or restitution period than men. Fancy word for if a man has an ejaculation, it takes him a certain amount of time to recover.
Like a day,
No.
That may be age related.
All right. Like 5 hours.
Okay.
After the game goes off.
You're right. Ultimately, I knew that this was going to go there. This is just but estrogen is important for that. So what happens when you give somebody estrogen?
Right.
They won't maybe talk to you about it, but remember I said the WAP, right? So they do notice that there's more natural lubrication that they now can make as opposed to not. And vaginal atrophy, as Halle Berry might say, this is not a nothing, right? Many women may say, I don't have a partner, so I don't think it's that big a deal. Lower lubrication leads to more overgrowth of the kind of bacteria in the vagina that lead to increased yeast infections, and in some patients more overgrowth of bacteria. So it's not benign. So having some natural lubrication is important. And then obviously direct stimulation. I'm gonna just say it because since it's PG-13, it's probably less than 10% of women are going to be able to orgasm without some direct clitoral stimulation. So it's not about vaginal penetration with the man's part that's going to get them there. They need some kind of either digital something to the clitoral area, right? Well, the problem with going directly to the spot is that it no longer responds the same way that it did, because that's about blood supply and oxygen. Same thing with men.
This is deep.
Right. So what does Viagra, what do all those medications do? They dilate blood vessels to increase the amount of blood supply to the area, and the way that the man's penis works is that more flow going in, slower coming out. Now you got an erection. So women, the clitoris is the analogous structure. So it needs a certain amount of blood supply in order to have stimulation that leads to orgasm. And without estrogen, it's going to take longer, and then the intensity with which you might climax is not as intense. Many of my patients tell me that. So they may not complain about that because they're not at that point, because they're not interested, and that is the most complicated. There was a great cartoon when my friend showed me a man and interest in sex is like a light switch. I don't want to offend anybody. You turn it on, and you're ready to go. But a woman is like dashboard in the cockpit of a plane. There's a whole bunch of things. Like I don't know which button to hit. And that's what estrogen is. A lot of people will say, well, I have the estrogen and I feel better and I got energy and I'm sleeping better, but I still ain't interested in him. Okay, we don't have an answer for that. And that little pink pill, so estrogen helps.
So girl, I saw his pay stub and just
Yeah,
didn't do it for me.
there you go. But there is something to be said for testosterone. That arousal and interest and libido, interest in sex, is associated with testosterone. But then remember what I said earlier, that there's more free testosterone in the menopausal transition than not. So why is it that if you have more free testosterone, why is it that you're not as interested? It's a complex question, but when you give
women
a
are
little
complex, without a doubt. So.
we are amazing. So
Yeah.
1/10
amazing
of
complex.
the dose of testosterone does seem to help.
So Lynn, okay, so you heard what she just said, right?
Yeah.
So
We're trying to get all your business, and let's just act like you're not on Facebook Live, and it's not going to go out everywhere, right? So it's just us here. It's just us.
Okay.
Close the door, nobody here.
And your gynecologist in the room.
Right.
So, could you share
Oh my God.
some of your thoughts about the libido during this transition? I mean, you may have been celibate all this time, but maybe you.
Oh yeah,
had a feeling,
absolutely.
Yeah.
I'm saintly.
Yeah. So, but perhaps there's some women out there who are
Right.
probably listening to this and saying, I can identify with her. Talk a little bit about your journey, particularly in light of what Dr. Hines just shared.
Well, let me just say kind of on a
You
high.
go clinical too because you're an RN.
Yeah.
She's super smart.
Yeah.
On kind of a higher level, let's try to avoid like lumping all women into any
There you
one category, because there are 20-year-olds who have a low libido,
Yep.
who are essentially asexual or very little sexual desire, right?
Right.
And that applies in the 30s, 40s, 50s, and 80s, right?
Yeah.
And so
We men need to hear this, so obviously. Yeah.
right.
Yeah.
So I mean, not all women were ever that interested in sex, and that can be as a result of a lot of different things.
Trauma, whatever else. Yeah.
Trauma, just not really having great exposure to it. Honestly, not having a very great partner early on can be like, is this all there is to it, right? Girl.
So you don't know how to do it.
I got but yeah, I think, you know, as I mentioned earlier, you know, it was a
She's
little.
going.
Hold on. But yeah, for me, I've always been a little bit more of a sensual person. So once I was able to get kind of my
Now, if your
those-
inbox on Facebook start getting hit up, so I'm just
Okay.
saying.
It's
You,
DMs.
LYN.
There you go. That's what I'm talking about.
But once I was able to kind of get a handle on some of the symptoms
Yeah.
of perimenopause, in menopause, it started feeling a little bit more myself, so to
Absolutely.
speak. And that's the thing, when people are going through that, they're not feeling themselves. So even if they are
yourself, you feel more
truly
freakier. What do
free-
you mean you feel just more yourself? Like what?
kind of one and the same.
Okay.
Tell
No,
it.
she's in a constant state of freakiness.
No.
She gave you a lead information for her inbox.
But for whatever feeling yourself is,
Yeah.
once you get a kind of a handle on some of those things that have made you not feel yourself,
Right.
and you can start to get back in touch kind of with your body and your sexuality.
Mhm.
And so that was how it worked for me. I mean, you know, it helps if you're in a relationship with someone and you're not, I mean, it is more difficult if you're in the process of dating and you're getting to know people and navigating all of that, because, you know, it just might be a bad day for you, and then you meet someone, you go out on a date, and you're sitting there, and it's happened, you know, I'm sitting there like sweating, and you're trying to be cool and trying to, hey, what's that over there, as you're wiping off sweat, and, you know, getting up and going to the bathroom, trying to kind of get yourself together and drink as much cold stuff as possible. So all that comes into play. And even though you're dating men that are around the same age, as little as our society is aware of what menopause and perimenopause is for women, they're even less likely to acknowledge that men are going through something similar, as the doctor talked about.
I know what you're talking about.
So we're still hesitant to kind of say, sorry, I'm just having hot flashes. You're not going to do that on a date when
Right.
you're first getting to know someone.
Okay, so let's talk about that for a second. So how do you do that? And you talked about this whole thing of shame and whatever else, and I know we had some conversations leading up to this in terms of preparation. You talked about because, you know, although you are in, you kind of transitioned to the more professional space and working in healthcare. You talked about sometimes being in the boardroom, maybe you kind of going through hot flashes,
Oh,
whatever
goodness.
else, and with a bunch of men, and the last thing you want to do, you felt hesitant to even like use your fan, so to speak, whatever else.
Right.
Talk about how do you navigate that, because men need to hear this, right? I know people are serious right now. So what are your thoughts about that? How have you navigated that? And what are some of your suggestions in terms of if you're in this perimenopause stage or whatever the phase is, how to sort of deal with them? Or get you to chime on Dr. Hines.
Well, one thing, I'm very glad that having a fan or using a fan has become a lot more
Yes.
normalized, right? I see men with fans sometimes, right? Because I mean, it's the human nature to get hot under certain circumstances, right?
Okay.
But yeah, it's not only is it kind of having to do with, you know, the woman's experience, but again, as I think I mentioned earlier, just the whole ageism in our society. And so, yeah, you're sitting in a boardroom having a meeting. You're one of the few women in there, even fewer people of color in the room.
Sell it.
And you know, you start just having these hot flashes, and it is very difficult. You have a variety of things, you know, that you kind of try to, you know, fan yourself underneath the table, get up and go to the restroom and try and cool off, and it just really can be such a distraction for you to where you're almost like hating your own body because you feel like your own body is hating you.
Did you hear this? Did you hear this as well?
Oh my God, yes. Patients will. You can almost tell who's just transitioned into the perimenopausal phase because the kind of intensity with the emails and the appointments that you're like, wait a minute, I know this lady. What is wrong with her? Like you didn't answer the email and did 2 hours is like, what is going on, right? And or they actually will say, I feel like I'm going crazy,
Right.
and that's a real unsettling feeling that you either, you know, other people notice that you're a lot shorter with them, that you're just not yourself. And you get enough sleep deprivation. Remember, I'm an obstetrician, so I see it on the postpartum side with people who have not had a chance to sleep well because they got a new baby.
Right.
Can you imagine what that's like when you're in your 50s and you're not sleeping very well? Your body is not exactly 20. And so you got aches here and there. You wake up thinking, who was I fighting in my sleep? You know what I'm saying? You're just like, I'm trying to get through. So I think that it's that empathy, that understanding, and more importantly, education to the general public about that. Once again, menopause is not a disease, and that if we are to understand, just like hypertension and diabetes, that you can address it and to make your quality of life better. And believe me, I understand what you're saying. And so I didn't necessarily make the decision. I'll share that I am using an estrogen patch because I think that it changed my life. I was powering through it. You know, I'm a strong Black woman, and I realized that, you know, it's only so much green tea and caffeine to keep me awake in the morning. You know, I'm dragging through. I'm trying to exercise. One of my best friends is a trainer. She's my sister, and she knows about, you know, decrease in muscle mass. And she's like, look, you're working out now not because you're trying to be cute. You working out because you need to be able to take a squat position when you need to pick something up. You need to not fall down, and if you do, you don't break something. This transition in life is about your quality of life, and it is clear that the people who are way more active, who choose better nutrition, and also people around you that support you, love you, give you grace, you feel better. But none of that's going to fix lack of estrogen. You got to recognize, is this something that I need? Are there alternatives? People will say it in a minute. Hines, I don't want to have them hormones. What can I do? Well, there's Estroven over the counter. It's a soy-based product. There's Remifemin. There's Black Cohosh. There's lots of different options. None of them, however, are as good as estrogen. And depending upon where you're getting it from, the source, it is either bioidentical, as in it's supposed to be as equal to what we call 17-beta estradiol, or is it from a source like the horse's urine that we don't use anymore? But ultimately,
horse's urine.
It's called Premarin. Premarin. Yeah, 2002 study. That's what I talked about. So
It's been used a lot.
yes.
Wow.
So ultimately, what did you ask? You said, what do all these things mean? They mean that we now, thank God, with the help of some strong influencers and Halle Berry, I appreciate how she got to that point to let us all know.
Shout out to Halle Berry.
That's right, and shout out to the Do Not Care Club that talks about the reality of, as you transition, you stop thinking about, I got a little bit of belly here, I got a little bit of back fat. Yes, please exercise and please eat well, but father time ain't no joke, or mother time. And ultimately, all of us, as my grandma used to say, you won't ride the hearse. It just is what it is.
Yeah.
So you get as much out of this body as you can, and you take good care of it because it will take care of you. And hormone replacement therapy, whether you have a uterus, don't have a uterus, is an option for probably most women who are deciding to use it within 10 years of their last normal menstrual period. And I really do believe can significantly improve the quality of your life. If you dating, obviously you ain't got to tell that man what you taking, or a woman, or whoever you with.
Right.
But I do believe that you don't have to suffer, and I think that's really important. One of the, I forget his name right now, the comedian that calls women vintage. Y'all know what I'm talking about?
Yeah, Dion Cole.
Dion Cole.
Yeah.
As a
And
vintage
how-
woman, I know
You know what I'm
exactly
saying?
what it is.
And
That
Dion
don't
will
sound very
say,
flattering, vintage.
well,
There's worse names. Than
red wine, you know,
Right,
vintage is
right.
good. It's a good vintage.
Right. Things go up in value over time.
That's what I'm talking
Well,
about.
if y'all like it, I love it. It's okay. Nice.
But you're right. We are a youthful obsessed culture.
Yeah.
So I don't think that that's necessarily going to change, but I think in avenues and venues like this, thank you, Carrie, that you are putting out the truth and the information such that people have a resource that they can look to and then know or at least see people that look like them and say, hey, maybe I might be having this experience. And so remember what you said about, advocating. They can now walk into the doctor's office and go, I saw Dr. Hines, I saw Lynn Beatty, amazing nurse, I saw Carrie, I want to ask my doctor. And they listen. And as I've said many times, if they're not listening to you, just get another doctor. A lot of people say, well, how do I do that? First of all, you're paying money for it. So turn your card over and call membership services and directly say that this physician or this clinic is not meeting my needs. You can do that with any insurance. I just feel like a lot of times patients feel like they can't say anything because somehow or another they've been educated to believe that the doctors know everything. I did go to school a long time, and I do believe that I am confident enough in my skill set as a board certified physician, but I don't know everything, and I ask a lot of questions of my colleagues and other subspecialties to help me. But what I do know is that you should never be with a physician that you don't feel like you can talk to. Period.
That's very powerful, right? So thank you for sharing that. Because I do believe there are a lot of men and women feel as though that, that whatever their physician says is gospel. Maybe they feel a little bit indifferent, afraid to ask questions. I think that's totally the case. Let's pivot really quick, actually more bullseye. Let's talk about men in this context. So it is my sense from, not just from being a man, but from just knowing other men, that we probably see menopause, perimenopause, whatever the cycle is, that it's either hot flashes or you have trouble sleeping. Almost exclusively that's it. I'm not sure many of us are aware of vaginal dryness, shifted moods. I mean, we'll just say, yeah, just a woman. And whatever, it's like, and it could be a whole other thing going on. So I have heard women talk about that they've gone through these things, and I've heard one friend, Kanika, she talked about how some women will, it's so bad for them, it's almost like two pieces of glass kind of scraping together when they're having sex, right? And I thought that was really popular. So what would you say, let's start with you, Lynn. What would you say to men, how they should navigate this time? Because everything we talked about, I guarantee you most men are not this sophisticated to assume that it could be some variation. It's like, she ain't feeling me, bro. Maybe I need to take her to Nobu and whoever else. This is my mojo, dang. I know I should have kept up like 2 minutes longer or whatever it is, right? We would never think that it's about some change, you guys. And if I'm really going to be honest, y'all don't really tell us.
True.
So we're just kind of left to figure it out. And even to ask or even insinuate it's something else, it's like that is totally out of the protocol and how you engage with a woman. So let's start with you, Lynn. What's your reaction to that? Then Dr. Hines, please.
Well, for one, I would highly encourage men, if they think that she's a little off or that there's, some...
Because we don't want to generalize, right? We
Right.
don't want to generalize.
What you don't want to do is saying, what's wrong with you? Are you perimenopausal?
You asking for it.
But no, what's what we're talking about, though? Why can't we just say that?
I think there's a lot nicer ways to say that.
See? Qualifying it. They're qualifying it.
No.
Tony, they're trying to qualify the bro. I'm like...
Well,
damned if you do, damned if you don't. Anyway, finish.
so let me flip that just real quick before I move on. Let's say as a man of a certain age, it's taking you a little bit longer to get going.
Oh my God, this is comedy. We must be informing the community.
It just makes a radar.
So just to flip the scenario,
Okay.
how would you like it if the woman just says to you, do you need a blue pill?
Well, that's more direct. That's like,
You have ED. Well, and you know what? You make a really valid point that I think communication styles between men and women are different.
right.
So yeah, maybe a man, if I said, if you need to take a blue pill, I can wait, or whatever, that you might be like, cool, I wasn't sure, so some men might take that well, but I do think there's a
Bro,
segment
I'm
of
confused,
men.
bro. I'm confused.
There's a segment of men that might take that the wrong way. I've known grown-ass men who are like, and I don't need to take no pills. Now, I just say to them, listen, God created the people who created those pills. If you need pills, then just by all means pop it, brotherless.
Just slide it to this. Just put it in his drink.
Just slide
So
it.
why all of a sudden I feel like Superman?
So as it relates to women, if she is seeming a little off, or if there's issues around like vaginal dryness or whatever, for one, I think just in general,
Men, we will immediately assume that if she is not wet, the vaginal dryness, that you must not be feeling us or something. We will never, ever assume it's based on something that's physiological that's going on with you. I know that for a fact. If she ain't wet, she ain't feeling you, okay, I knew you were watching that dude over there. See, you're not even, I'm telling you, we will take ownership of that.
Are you saying that men are not even interested in, lubrication? Like, I haven't gotten that impression over these 25 years of practice that talking about using a lube is, an issue.
It's probably early on
Got it.
where a man will go like, well, she's not wet, whatever the case may be. Now, into the relationship is very possible that
Got
they
it.
sort of understand, but I'm just saying early, more,
You're right, you dated.
Yeah, you're dating, yeah.
Well, yeah.
well, for one, just in terms of women and having agency in our own bodies, I think we should have our own lube with us.
Okay.
Just like the women should have their own condoms. Just because you shouldn't leave it to another person to make sure that you're having safe sex. So that kind of all goes with it. I mean, if you're using condoms, the lube really helps in that way too. I'm not trying to get too graphic, kids. But I'm just saying that. Just as women, hopefully we kind of are aware of some of these changes. We may not fully understand them, but we can sense when maybe with sex there's not as much lubrication naturally. So we should have our own lubrication ready to go. And I don't know, the man shouldn't take offense to that. I mean, there's a lot of things he can do that can help with that, and so it may not be necessary. It's good to have it on standby. But yeah, I mean,
I just think there needs to be some level of dialogue so we have a general sense.
I think once the relationship is at that point.
Yeah.
But sometimes in some relationships you get to the sex part before you get to the deeper understanding of each other part.
Sure.
It should be the other way around, but I'm not here to judge. And I'm not here to say that I've always done it in the right order. I'm just saying that it's still, I think,
I had no idea this was going to be such a freaky conversation.
it's hopefully becoming less and less of a hesitation, but I do think that you should feel comfortable saying that at a certain point. But as Dr. Hines mentioned, some people are perimenopausal in their late 30s.
Yeah.
That's a hard time to bring up anything with the term menopause in it.
Yeah.
Right.
Even if it's perimenopause, men don't understand the nuances of perimenopausal, menopausal,
No, we don't.
and all that.
No, we
So
don't.
if you are 38 years old and you're dating someone and you already are kind of feeling weird and having these other things going on, but now it's time to get intimate, you don't want to say, oh, I think I'm perimenopausal, so I'm going to start using this lubricant. I mean, that is going to go south, I think.
Yeah. Yeah.
So it sounds good on the surface to say that women should be sharing that with men and men should be receiving it well.
Right.
I just don't think that that's realistic, certainly in the earlier phases. Once you guys are closer, you're talking about all sorts of things, talking about a future together or whatever, then you can share with him that, you know, you might have some other health concerns. And I think also as you get older, you can talk about health issues a lot sooner in getting to know someone, you know. At a certain age, you know, I've had men, maybe it's because I'm a nurse, but they tell me all kind of health things, and I'm like, I do not want y'all broke down self.
My trigger finger.
My eject button.
You're like, run that by me again.
Right, so that's also the danger of being a nurse and dating people,
Right.
you
Yeah,
know.
you're like,
They want to bring everything to you.
Right, but at any rate, I do think it's something that should be a safe space to discuss at a certain point in the relationship, especially as you guys are getting to know each other. And maybe you are having a really off day. You didn't sleep well last night. You're having hot flashes. I think you should be able to say to him, and he should be able to receive, hey, I'm a little off today because I think I'm perimenopausal. You know, I'm trying to see what I can do about that. But please, you know, if I'm off, it's not you. You know, unless
It's not you, it's me.
right, but and you know, and it is, but I think sometimes it might be him, and that needs to be addressed in its own way.
Right.
But yeah, I mean, I just think it's still, it hopefully will get better over time, but I think also like 37, 42, that's a hard conversation to have, and so, but once you get closer, and kind of just one little thing I wanted to mention, because I heard it on another podcast, is that like at a certain age, around perimenopause and menopausal period for women, that the divorce rate goes up significantly.
oh yeah.
And so,
Interesting.
and so I think not only for dating, but even if you're in a relationship, that being self-aware of what's going on with your body is so important, so that you can do something about it. And in that instance, you really should be able to have that conversation with your husband or your long-term mate of what's going on, so that maybe you can avert, you know, ending the relationship when it could be that you just need medication.
Right, especially libido. Like if you're just not interested in being intimate, and he may, as you said, take it as rejection of him,
Right.
as opposed to
I bet 9 times out of 10 we would take it as rejection.
Sure.
right, and
Because
it's
y'all always making an excuse. We're saying this, but they really mean this, and whatever. It's confusing
right,
for us.
right, and so you know, too many times she's had a headache. Too many times she's not interested. She goes to sleep. I love to sleep. I'm gonna. My husband knows we have been together 29 years, married, and 33 together. He knows that despite the fact that I am an OBGYN and I'm up many hours of the day, I like to sleep. So I have to sleep. And so if I get a chance to sleep, you know, you can have your way with me. But otherwise, I can't talk to you right now. And that's not going to be what you think that is, because I will be bad in fish in the bed.
Okay, so
Dead fish. Like,
so one thing I want to talk about, I know we're getting close to our time here.
oh, yeah. Sorry
But
about that.
we got a couple more minutes. So, but Dr. Hines, I want you to sort of talk about, now I recognize that you're OBGYN, but I
Yeah.
know your unofficial other title is therapist and psychologist when you're talking to a lot of your patients.
You mean listening to me?
Listening, exactly. So when they talk about this is that and whatever else, I'm sure a lot of things that Lynn talked about in terms of conflict between the man and the woman and rejection, or even something leading to divorce, is probably come across your way, you know, treating your patients and things like that. How do you help them navigate that, and what would you say to the men and to the women based upon really understanding this time in a woman's life?
You know, it's interesting that it's rare, despite how disturbing hot flashes are, it is rare that people talk so much about hot flashes that it really disturbs their relationships. I don't know how that happens, but I would think that that's pretty big. But what comes
I'm
to
talking about even outside the hot flash.
I got you. Let me bring this in, and I want to add it because this is I think caused enough conflict that relationships have terminated because of it, and that is that dryness in the vagina associated with overgrowth of bacteria. There is an infection, although it's not sexually transmitted, but it is sexually associated. It's called bacterial vaginosis. This is important. Bacterial vaginosis causes this kind of thin discharge, and more importantly, it's fishy. Now, it's the most common discharge, not like yeast, believe it or not, is the most common cause of vaginal discharge. And it's not just you see it in young women, but you definitely see it in older women because they no longer have the protection of the good bacteria in the vagina because they don't make the estrogen that helps to make the natural lubrication that leads to less overgrowth of bacteria. You with me? So I have had many a man come to the visit with his wife or girlfriend who is very concerned that this discharge or this recurrent infection is from him, keeping him from being sexually active. All of those things is extremely important. It's really important.
Interesting.
The other issue is that women can have pain with intercourse, but because it depends on the woman, they're very socialized to please their man. So they will literally be in horrible pain.
Yeah, that's what I've heard.
In order to say, I don't want him to go someplace else. And yet we all understand, you get to this age, he gonna do what he gonna do. You ain't gonna stop him if he decides he wants to be with somebody else.
Right.
So it's about his commitment to you. And if you can remember that, then you can broach the subject no matter how uncomfortable. You cannot just say it. I feel uncomfortable saying this to you, but I gotta say it. And then usually, clearly he loves you. He'd be like, well, what can I do? And my favorite store is the pleasure store in Santa Monica. The front part. The back is a little.
Where is this?
The back of that store is a lot of S&M and some real wild stuff. But the front of the store is every toy, gadget, cream, gel, you name it. And the people.
You never go to the back of the store?
I've been back there. And I turned around and came back to the front. That for me, that's not where I can be. Okay. And my partner is looking at me like, I'll go with you to the front of the store. You know what I'm saying? Like, we're not in the back of the store. But I say those things to say that when you are as comfortable as maybe you can be, both, I tell patients, you need to stimulate the area. If you are not getting stimulation from a partner, then stimulation from some device, whether it's the rose, the something, increases blood supply to the vaginal canal, increases natural lubrication, increases the likelihood of better sexual response. More importantly, that you can tell your partner what you like and what you don't like. So I clearly am a different person when in my 20s as opposed to at my age now.
Right.
And I saw, once again, a podcast the other day with the Ball brothers that made a comment about, well, I like to do so-and-so, and they were all laughing about what the man was saying he likes to do to stimulate his wife. He says, look, I ain't got time for all of that. Look, this is what I'm going to do. I know her well. We done. Let's go to bed. And I was dying laughing.
That was Kev on stage.
That was it, right? Right? Because he's making a joke, but he's laying out a foundation that when you know a partner, or you're comfortable enough with the partner, that you can have whatever quality or kind of intimacy that you like.
Right.
And I think that ultimately what you talked about, dating is still based on relationship. It's the introduction of a new relationship. And you're trying to navigate that process and spend more maybe intimate time together. If you're honest with yourself about what you think you like, you can pick up real quick. Most women do. I've read that someplace where it says, and I believe it, that within a very short period of time, you can decide whether you think you sleep with him. And it's all a matter of moments to decide, nope, I'm serious, right? So you meet him and you're like, oh yeah. And then he starts talking, and he starts doing something, and then you're like, not gonna happen, right? So I figure, right, in that short period of time, you're like,
Exactly.
So you say you if you're dating women that are in their 40s and 50s and they're amazing, that you, I think, more forgiving about what that body looks like, because we are.
Right.
And then as you are deciding you want to be intimate, put your cards on the table, right? Yeah. And really talk about what's important. My favorite liquid, my favorite lubricant is called Sliquid. It's liquid with an S in front of it. Amazing. A couple drops will do you. I'm a gynecologist. All right, so Sliquid is excellent. Best condom out there, 004. It's called Okamoto. It's made in Japan. Kind of expensive, but you're worth it. It is about $3 or $4 a condom. You can get it on Amazon, although we're not supposed to shop it. But anyway, it's an amazing condom, and my husband has done field research with me, so I can tell my patients, about what, good condoms, good lubrication, and good communication. There you go.
Interesting. Wow, well, we've come to the end of our podcast, but we want to wrap up. We want to give us like 30 seconds of wisdom, Lynn. what would you like to say to the people out there, kind of to put a bow on this amazing again, I didn't know it was going to get as freaky as it was. But man, go ahead, break it off.
Good freaky.
Yeah, I would just say that as women, you know, we need to advocate for ourselves. As I mentioned, I changed the doctor I was going to in order to make sure that I was not suffering any more than I absolutely had to. And in doing so, that allowed me to then interact and, you know, interact with people in general by day and by night. But certainly that helped from the dating front. And if your body changes, as Dr. Hines has said, his body's changing as well. And just kind of embrace your body in the different periods and the new curves or the new proportions or whatever, because as
and man boobs and all that.
well, yeah, him with man boobs, mine, anyway. But just, you know, learn to kind of be comfortable in your own skin, and I think that's easier also as you get older, as compared to when you're in your 20s and 30s, to just kind of learn to love yourself, and then that's how you can kind of better communicate with whoever you're dating or the man or the woman that you're with through all the changes that your body are going through in perimenopause, menopause, and postmenopause. That's what I would say.
Awesome. Thank you, Lynn. Dr. Hines, please share your topic for us, please.
Menopause is not a disease, but it's certainly a condition and a state of being that can be addressed and increase your well-being. You can be as sexy, I think, at 50 as you were if you think at 20. I think you are, to me, more sexy as you get older when you can take all your clothes off. Here it is. And you don't have to worry about, look, you know, think about what that body is done for you. As a physician, I think about, you know, this body has had 2 children and it has, you know, kept us, you know, clothed, and we got food on the table, and me and my husband are working together and taking care of our kids, and this is that same body that has done so much for you, and it's transitioning. It's not diseased, it's transitioning, and it's moving into a new phase. And so I say, talk with your doctor, and if you don't like what they're saying, or not necessarily, maybe I can't say you don't like, maybe you don't like, but get another one. You know, use this podcast as a resource to say, I can actively advocate for myself and make sure that you get what you need. The Pleasure Store in Santa Monica, they don't pay me for this, but it's an amazing place to do some field research.
Right.
Condoms keep you from seeing a gynecologist on a free, you know, and I think it's also important, you don't need to be so friendly with your personal parts. You can be very discerning. Nobody is worthy of you with all your skills. You know you got it. So hey, be careful who you give it to. I'm a little crazy, but you know.
No, you've been all
Okay.
boy. Oh my God.
Thank you so much.
Oh yeah, this is awesome. Okay, so we need a big round of applause to our healthcare professionals here. Dr. Tanya Hines, MD, OBGYN, and Lynn Beatty, RN, MBA.
She's amazing.
Big round of applause to them. They've been amazing. We want to thank also our sound engineer, Tony Nuncio, as well, on the ones and twos back here, and beautiful Charmaine Carter, helping part of the Urban Birds and Bees team. And for, again, this conversation was about perimenopause and dating. So hope that you guys learned a lot out there in Facebook land and here that's going to be recorded. I am Dr. Kerry Neal for Urban Birds and Bees. Till next time, we're out. Thanks for joining us.
Yay.
Wow, I think I got educated in one setting.
I
definitely want my wife to visit you, and not out of, you know, we're the same age. I'm 65, she's 65, and just through those conversations that
you were
Oh
having,
yeah.
amazing.
And Lynn is amazing. I love how she said, no, maybe you got a problem. I love it. You know, you out there dating, right? You're like,
that was a brilliant podcast.
I love what you said about communication.
Oh, yeah.
Somebody asked me, they go, Tony, what's the secret to keeping a relationship? Communication is number one.
Absolutely.
Because through communication, you're going to discover what she's feeling. Through communication, what she's not wanting. And that's our job, is to hear the woman no more than the woman hears the man.
Absolutely.
Somebody says, how do you know what a woman's going? I think, look, we all have X and Y's, correct? I think if we men can connect with our feminine side, and women can connect a little bit of the masculine side, like just, you know, the estrogen versus the testosterone. I think we would we had it right before I was telling Dr. Carey, I have 2 daughters. And they go, Dad, no. They were arguing because they wanted to be right. I said, you want to be right? Learn to be wrong.
Say it. Or do you want to be right and you want to be married?
My other youngest daughter, she goes, Dad, I keep going out to this one club and the guys are all assholes. Oh, wait a minute.
Maybe don't go to that.
Where's your watering hole? Where are you fishing for this?
There you go.
Because you're getting the same outcome.
Right.
Different guy, same outcome.
Yeah.
Different guy, same outcome. Maybe it's time to change your watering hole.
There it is. There it is. And I think subconsciously, you asked a question, Carrie, Dr. Carey, about, you know, all of the intimate and special things that people have said in confidence to me as patients.
Right.
And there are some generalities there that I think are really important, and that is that women want so much to be loved and cared for, and that they're willing sometimes to sacrifice their own safety and health to do so.
If you were to talk to my wife, she says, okay,
That
your
is,
husband works 12, sometimes 13, 14 hours, as you know. Sometimes 6 days a week, trying to get this company going. Ask her who cooks breakfast in the morning, lunch, and dinner when we're together. I love doing that for her. And I said, honey, I'm going to make some breakfast. You want to eat? I want to make it. She goes, no, I don't want to eat. I go, okay, you always say that, but then here comes the smell. You're like, oh, you know what? That's really good. I go, why don't you just tell me yes, so I can make extra? But it really comes down to communication.
It does.
It really does. I was impressed. I was very impressed with this.
and also too, listening to all these years, you know, of being a physician, instead of listening for the answer, right? Just listen to the patient.
Oh, interesting.
So I have students, you know, and the student goes, the patient presents, she's 32-year-old, gravid or something, Peri something, presents with complaints of such and such. And I'm like, why did she say that was a cheap complaint? Now, they tell me the cheap complaint. I ask, why? And that question, I think, that makes younger in the career, I'm trying to teach the students, the why will get you faster to the plan of management than the what did you say. That makes sense, right? So there are plenty of patients that say that I have this recurring vaginal discharge, or I have this pelvic pain right here. And if you just say, well, how is that affecting your life, or what's really happening? Oh, they will tell you about how it affected a relationship. They will tell you about, I think that's why I can't get pregnant. I think, oh, now you're getting at it, right?
Right.
Versus, here's some yeast medication, see you later, blah, blah. Right?
Wow.
So it takes a little bit more time, but then over, and if you just act like you care, they will tell you what's wrong. And then you're like,
You're getting so much out of this doctor, but
Yeah.
by doing exactly what you're doing, is not only do I have a doctor with me, but I have like a combination of therapists as well, because she cares. And like you say, just act like you like really question it and ask her.
And you know they don't give us but like 18 minutes, right? With each patient.
Wow.
And the nurses stole 10 of that.
Wow.
So
Yeah.
I'm just saying, I love them.
Modern health.
But you know what I'm saying? So, right,
That's
so you
awesome.
just sit there and you're like, okay, I'm just doing the best I can. And I have my days, don't get me wrong. And I'm like, look, I'm going in here, I'm doing this pasture, I'm out of here, I ain't got time, I got to get out of here. As soon as you sit down. And that's it. And you're
You're
like,
human.
I ain't gonna get out of here on time. That's what I'm saying. But I can still do that pasture in 5 minutes, but she needs it to be heard.
Yeah. Yeah.
And then once you get it, you're like, you know what? So here's what we're gonna do. I'm gonna address that. And this is what I need you to do. Here are the labs. Here are the whatever I need you to do today, or before I see you again. I'm gonna do your PAP right now. So let's get that done. And then we are gonna come back in 3 weeks, 4 weeks, and we're gonna go over this. We do virtual visit, in-person visit. And so now they're like, oh, she heard me.
That's huge.
So within healthcare, them little 8 minutes I got, I give her all the 8, and then I put my labs in, I'm always late, do the PEP, and then the patient comes back, right? So, and I think that helps a lot.
Yeah.
I feel like, I don't know. If I'm a different doc now than I used to be maybe when I was 20 and 30, but I was still basically the same person.
Sure.
I got better now. I'm really because I'm real efficient, right? But it's still a human business.
Oh yeah.
And especially gynecology. Right? So people ain't trying to tell you their business because you all up in the business, right? So you have to be.
Don't be judged this. Well,
Yeah, and you in your brain, you're like,
Oh, I've heard it all, honey. You can't shock me.
right? And so you got to get your face right because you're like, did she just say? I'm like, okay. But then why is she saying those things that sound so crazy to you, right? And you're like, why is she putting herself in danger? Do you see what I'm saying? There's a whole bunch of people say that I'm not planning to be pregnant, and yet they keep laying down with a partner without using protection.
Right.
That's called planning a pregnancy.
Wow.
A new scientific term called parenthood, right?
Yeah, that's called parents.
That's
right?
another podcast, right?
Yeah.
Yeah.
But what it is, they got a good commercial. Somebody brought it up. Y'all seen that commercial where the people take PrEP, right, for prevent HIV, and they have a couple of the people that actually say, "Well, I never really thought." That's the truth. It's the truth right there. It's like, well, I never really thought that I needed to be tested, or I mean, who has time to get tested? That is the truth. Whoever did the planning for that commercial is the absolute truth, because people do not come up HIV positive, for that matter, gonorrhea or chlamydia positive, because they planned it.
Right.
They didn't plan to prevent it.
Right.
And they just didn't think it was going to happen.
To them. Right. Wow. This is deep. Shoot.
That's another podcast.
That's another podcast.
Podcast too?
Yes.
Tune in.
My girlfriend wanted to do something like what you're saying, and we laugh so much together because she is wild. And I said, I can't be on a podcast with you because I'm gonna say something.
I love the whole comedy aspect of it too, because you're sort of like, it's not so direct and so serious, but at the same time, the message is serious, but we're gonna lighten you up a little bit.
That kind of helps we know each other too. But
Well, Lynn is fun.
Yeah.
And I just sometimes you just touch her head and go, I am with you.
Exactly.
That part.
Exactly.
She's like, I didn't tell you to take the pill. I went, that part. You're like,
Take a picture. Gotta take a picture.
Or should we stand?
this is good. I guess your lighting's good here, right?
Yeah.